Hi, I'm Dr. Stephanie Valente. I will be talking about breast cancer. So, breast cancer can present in a lot of different ways. And on what you're going to find out is that you're going to get abnormal mammograms. So, a mass, asymmetry, calcifications. The core needle biopsy that's performed for any of the above is going to give the diagnosis of breast cancer. Diagnosis of breast cancer, usually three main types: ductal carcinoma in situ, invasive ductal cancer, or invasive lobular cancer. On a core needle biopsy, breast cancer receptors can be identified. So this is what's called the tumor biology. What type of cancer is it? So the three receptors that we test for are estrogen receptor, progesterone receptor, or the HER2 receptor. Let's look at this. Cell on the right. So this is a normal breast cell. So the best way to think about it is that a normal breast cell has an estrogen receptor and a progesterone receptor. The hormones in your body, estrogen and progesterone, float around in your bloodstream, attach to this breast cell, and that's what tells the cell to grow and divide. So this red cell over here is a cancer cell. So when we look at this cancer cell, we say, does your cancer cell have the estrogen and progesterone receptor? Meaning, is that cancer cell growing and dividing in response to estrogen? Or has it lost those receptors and it's kind of growing with a mind of its own? HER2 receptors usually aren't found on breast cells or cancer cells. So if it has that receptor, it essentially has kind of developed a way to grow and divide on its own. So a normal breast cell is estrogen positive, progesterone receptor positive, HER2 negative. Ductal carcinoma in situ. So let's go over this first. This is stage 0 breast cancer. So this is breast cancer that has not invaded through the basement membrane. It usually presents as branching calcifications on a mammogram. Paget's disease of the breast is actually DCIS of the nipple. It presents as a scaling lesion of the nipple, almost looks like nipple crusting. Somebody complains that there's flaking of their nipple that just doesn't seem to go away when they wash it. But that's ductal carcinoma in situ of the nipple is Paget's disease. For DCIS, we do not test HER2. We test for estrogen receptor and progesterone receptor. How do we treat DCIS? Well, DCIS is treated just like any cancer. The patient has two options for removing DCIS from their breast. First, they can have a lumpectomy. A lumpectomy, the margins needed for DCIS are 2 millimeters all the way around. After a lumpectomy, the patient heals up for about a month and then receives whole breast radiation. Radiation helps prevent it from coming back. A lumpectomy for DCIS, you don't need to do a sentinel node biopsy. And so if you think about it, by definition, ductal carcinoma in situ hasn't gotten outside the milk duct. So if it's not outside the milk duct, it shouldn't be traveling to the lymph nodes. So there's no need to do a sentinel lymph node biopsy. And if you're performing a lumpectomy and it's found on final pathology that what you thought was ductal carcinoma in situ is invasive cancer, you can always go back because you have the breast. You can identify the drainage pattern of the breast and perform a sentinel node at a second procedure. But it normally should not be performed at the original lumpectomy. The other option for DCIS treatment is a mastectomy. So no matter how big or small DCIS, even though it's stage 0, a woman always has an option for how they choose to get rid of their breast cancer or DCIS. So a lumpectomy or a mastectomy could be indicated. With a mastectomy, you are removing the breast. So even though it's DCIS, shouldn't be in the sentinel nodes, you're essentially removing the drainage pattern of the breast so that on final pathology, if invasive cancer is found, you can't really go back and do a sentinel lymph node biopsy. So a sentinel lymph node biopsy is indicated for a mastectomy for DCIS. And the overall risk of upgrading to an invasive cancer for DCIS is about 30%. Ultimately, after removal of DCIS, because it's not invasive, the recommendation would be to take endocrine therapy. And so endocrine therapy would be, your tamoxifen if you're premenopausal, an aromatase inhibitor if you're postmenopausal, and that helps decrease your risk of getting a breast cancer in that same breast or the contralateral breast. So what is tamoxifen? Tamoxifen is a selective estrogen receptor modulator called a SERM. It reduces the risk of recurrent or contralateral breast cancer by about 50%. Some of the side effects of tamoxifen include increased risk of endometrial cancer, about 1%, increased risk of DVT, especially in smokers, and increased risk of stroke. The benefits outweigh the risks in an overall average person. Let's talk about invasive breast cancer. So invasive breast cancer can be one of two things, either invasive ductal cancer, which is the most common, or invasive lobular cancer. Breast cancer can present as a painless, firm, fixed mass, or it can actually be non-palpable and identified on the mammogram. Sometimes you can see skin retraction, nipple inversion, ulceration, periodo orange, or axillary adenopathy. Preoperatively, you want to get an axillary evaluation to see whether or not clinically it appears that the lymph nodes are involved with cancer. So you can do this on clinical exam, axillary ultrasound, or a breast MRI actually can look at the lymph nodes as well. Lymph nodes that are greater than 1 centimeter in size, have a thickened cortex, or loss of fatty hilum could potentially be suspicious for cancer in the lymph nodes. If clinically suspicious, the lymph node should have an FNA or a core needle biopsy performed to prove the diagnosis of cancer. If cancer is in the lymph nodes, this is an indication for a staging workup to rule out metastatic disease. So systemic staging workup should be performed for known axillary metastasis or if the patient has any systemic symptoms of cancer anywhere else in the body. So what are those to look for? Shortness of breath, bone pain that's abnormal, falling, dizziness, increased headaches, or any abdominal pain. The big places that breast cancer can spread are to the bones, the lungs, the liver, and the brain. Staging workup can be one of two things: CAT scan of your chest, abdomen, and pelvis, accompanied with a bone scan, or a PET CT. Now stage. Stage is based on tumor size and nodal status. Let's go over stage. So TIS means invasive cancer, that's stage 0, that's DCIS. Stage 1 is for an invasive cancer less than 2 centimeters in size. T1 is less than 2 centimeters in size. T2 is 2 to 5 centimeters in size. T3 is greater than 5 centimeters. And T4 is inflammatory breast cancer, any cancer that's involving the skin or chest wall. N is lymph nodes. So N0 means no lymph nodes are involved. N1 is 1 to 3 lymph nodes. N2 is 3 to 10 lymph nodes. N3 is greater than 10 lymph nodes. And then M is either M0, not metastatic anywhere, or M1, metastatic disease. The good thing about breast cancer is that survival is based on stage. So survival is not based on tumor biology or type of surgery. More importantly, it's based on stage. And survival is based on stage. So if you look at it, the earlier you catch a breast cancer, the better the survival. So the importance of mammograms, self-breast awareness. So let's go over the timing of breast cancer treatment. So breast cancer can include surgery, chemotherapy, radiation therapy, and endocrine therapy. And traditionally, if the cancer is small and appears to be localized to the breast, surgery would be the first mode of treatment. So surgery to remove the cancer, chemotherapy if it's recommended, followed by radiation therapy. And then if the patient's estrogen positive, she would receive endocrine therapy. Now, adjuvantly, that's where a lot of research is coming, but if somebody is HER2 positive, they would receive trastuzumab for 1 year after their surgery to help prevent recurrence. Now, there are some instances where chemotherapy is given neoadjuvantly. But let's talk about surgery first. So if we have somebody with an early stage breast cancer who's going to go to surgery first, there's really two parts of surgery that we need to discuss with the patient and plan for. The first one is lymph node evaluation, and the other one is the actual breast surgery component. So let's talk about management of the axilla first. So everybody has about 10 to 30 lymph nodes in their axilla that drain the breast. So the right breast drains to the right axilla, the left breast drains to the left axilla. We know that the breast always drains the first 1 or 2 lymph nodes before it goes to the rest. We know how to identify that drainage pattern to perform a sentinel lymph node biopsy. So removing all of the lymph nodes increases the risk of lymphedema, which is permanent swelling in the arm. Removing all the lymph nodes, risk of lymphedema could be anywhere from 15 to 30%. More specific localizing sentinel lymph nodes increases the risk of lymphedema by about 2 to 5%. So we want to decrease the amount of morbidity, but appropriately stage a patient by checking their lymph nodes. So how does a lymph node biopsy work? So the recommendations for the highest success rate is use of dual tracer. So you can inject the tracer one of two ways. One called peritumoral, so inject it around where the tumor is, or periareolar. You are going to inject nuclear medicine, technetium-99. You can or cannot obtain a lymphoscintigram, which is a picture of where that technetium-99 is draining. It should ideally drain into the axillary lymph node basin. And then at the time of surgery, you're going to inject a blue dye. So the blue dye is either methylene blue or isosulfan blue. Both have risks associated with them, but both of them work just as well. So methylene blue can cause skin necrosis. Methylene blue is not good to use if you're performing a nipple-sparing mastectomy because it can cause nipple necrosis. Isosulfan blue can cause an anaphylactic reaction. So again, risk and benefits of both. So once both radio tracers are injected, you're going to use some type of gamma or neoprobe to identify where to make your incision and where most likely the lymph node would be identified. Using that gamma probe, you're going to identify which lymph node we call as hot, meaning which one carries the highest signal of the technetium-99. Once you dissect that lymph node down, it'll be confirmation because it will be stained blue. That way you know that lymph node is considered hot and blue, and that would be removed and sent to pathology. Now the rule of 10 is that you're going to take out any lymph node that's 10% of the hottest lymph node. So if you identify a lymph node that has counts in 1,000, then you would need to remove any other lymph node that has counts higher than 100. So rule of 10. When are you done with lymph node biopsy? So when there are no other hot, blue, or abnormally palpable lymph nodes identified, that's when you know the sentinel lymph node portion of the surgery is complete. And you're actually removing the lymph nodes and sending them to pathology. So let's go over sentinel lymph node biopsy in a clinically node negative patient and what's called the Z11 study. So what this looked at is this said patients with clinical T1 or T2 and N0 disease who are undergoing a lumpectomy, who are going to receive whole breast radiation, sentinel lymph node biopsy can be performed. Now here's the caveat. That is if on pathology you find 1 or 2 lymph nodes that have metastatic disease, that third and fourth or however many lymph nodes you remove are clear, so there are no additional lymph nodes, 1 or 2, and there's no extranodal extension identified, then you don't need to perform a full axillary lymph node dissection. And that's if it's limited to less than 2 lymph nodes and the patient's having a lumpectomy with radiation. Traditionally, any one lymph node would trigger complete axillary lymph node dissection, but this study came out and this shows that it's safe if you have 1 or 2 lymph nodes and the patient's having a lumpectomy to not perform any additional axillary surgery. Even more so, if a patient has metastasis clinically in N1, so this is 1 to 3 lymph nodes, positive for metastatic disease. These patients are candidates for neoadjuvant chemotherapy, and I'll go into that in a little bit. But if neoadjuvant chemotherapy, they go back, they get their imaging, mammogram, MRI, ultrasound, and it looks like they have what's called a pathologic complete response, meaning that there's no residual abnormal lymph nodes, and so they clinically appear to be N0. They're candidates for sentinel lymph node biopsy. And there are studies that have shown this. The one that I picked for this talk is the 1071 trial. And so this is patients with N1 disease who underwent neoadjuvant chemotherapy who are now clinically N0. They can go to surgery, and before they would, if they had surgery in their lymph nodes, regardless of how well it looked like after treatment, they would get axillary lymph node dissection. What this study says is that if they're N1 turned clinical N0 after neoadjuvant chemotherapy, you use dual tracer as I discussed before. You're going to remove any lymph node that has a clip in it that confirmed biopsy proven lymph node mets, and remove at least 3 sentinel lymph nodes. That if that lymph node that was initially biopsied positive for metastatic cancer is now negative, no further surgery is recommended. You don't have to do an axillary lymph node dissection. If those sentinel node or nodes continue to be positive pathologically after neoadjuvant chemotherapy, that patient has residual disease and needs a completion axillary lymph node dissection. So what is an axillary lymph node dissection? So an axillary lymph node dissection is indicated for anybody who goes to surgery that has lymph node positive disease. So this is what you're going to do. A lymph node dissection for breast cancer consists of a level 1 and level 2 dissection. This is defining the border. So a level 1 is lateral to the pec minor, level 2 is beneath the pec minor. Now level 3 is what we used to do with a radical mastectomy, but we don't do that anymore. But those are lymph nodes that are medial to the pec minor. Rodder's nodes are lymph nodes that are located between the pec minor and major muscle. So for an axillary lymph node dissection, which again is level 1 and level 2, there are anatomical landmarks that I'm going to walk you through. So anatomically, superiorly, the dissection is going to go to the axillary vein. Laterally, it's going to go to the edge of the latissimus dorsi. Medial, it's going to go underneath the pectoralis minor muscle, and then posteriorly down to the subscapularis muscle, and then medially again here, it's the serratus muscle. What nerves do we need to watch out for? So number 1, there's a sensory nerve, and that's the intercostal brachial nerve. So that runs from about interspace T2 into the upper inner portion of the arm. This gives sensory to the medial upper arm. Intercostal brachial nerve. The thoracodorsal nerve runs with the thoracodorsal bundle, and this is coming down and it innervates the latissimus dorsi muscle. It's a motor nerve. It runs along with the intercostal, the thoracodorsal nerve, artery, and vein. So if this thoracodorsal nerve is cut, it limits the ability for abduction and internal rotation. So this is kind of your pull-up nerve. The long thoracic nerve runs on the lateral anterior portion of the serratus anterior muscle. This needs to be identified and preserved as well, and if it's cut, this creates a wing scapula. So let's talk about breast surgery. Now we've got the axillary parts. What do we do with the breast surgery? So there's two ways, as I mentioned with DCIS, to treat invasive breast cancer, and that's lumpectomy followed by radiation or a mastectomy. Now, if somebody has a mastectomy, they have two options. One is they can be flat and wear a prosthesis in their bra, and the other option is for them to get immediate reconstruction or delayed reconstruction. Let's go over a lumpectomy with radiation. So a lumpectomy, how you usually start is you're going to use, here's a mass here, here's a little clip in here. You're usually going to put a wire in, or you can use a radioactive type of seed. And the goal is to remove the cancer with a clear margin of normal tissue. One of the biggest risks of a lumpectomy is not getting it all the first time. And so when I go over this with patients, I say, listen, cancer, you can't see cancer. Our breast is all yellow color. Cancer doesn't show black or anything abnormal. So across the country, the risks of needing re-excision for a lumpectomy for not obtaining clear surgical margins is about 15 to 30% chance. So again, margins. For invasive cancer, a clear margin is no ink on tumor. A 2 millimeter margin for DCIS. And then after a lumpectomy with clear margins, the patient usually heals up for about 4 to 6 weeks and then will receive radiation. Radiation decreases the risk of it coming back. So looking at the B06 data, a lumpectomy by itself without radiation, the risk of it coming back in the next 20 years is about 39 to 40%. Radiation decreases that risk of a local recurrence down to about 14%. I always tell women the risk of getting breast cancer without any family history is 1 in 8, which is 12%. So 14 is pretty much back to normal. Again, the risk of dying from breast cancer is based on the stage, not the type of surgery they pick. So what are some contraindications to lumpectomy or what we call breast conserving surgery? So if somebody's thinking they want a lumpectomy, you kind of have to go through with them and make sure that they meet the criteria for that. And so anybody who's had prior radiation, so treated breast cancer before with radiation to that breast, you can only get radiation to each body part kind of essentially once. So prior radiation, so that would be prior breast radiation for breast cancer or mantle radiation. Also a large tumor to relative breast size. So you've got a large cancer and a small breast. Taking that lump out is going to give that patient with a cosmetically not pleasing result. So that's not a good option for them. Anybody who's pregnant in the first or second trimester, you can't give radiation during pregnancy. So if you calculate it and say by the time they have their lumpectomy, maybe they're going to get chemo and then they'll get radiation. If the calculation fits that they're going to deliver the baby before they need radiation, that's an option. But if you're falling into that surgery and then radiation a month later and that patient's still going to be pregnant, they cannot have radiation. Or inflammatory cancer. So inflammatory breast cancer, diagnosed again from the benign breast lecture by a skin punch biopsy, is a contraindication to breast conservation. So what is radiation? Goes along with the lumpectomy, it improves local control. So the goal of radiation is to eliminate residual microscopic disease, especially but only when the margins are clear. So radiation doesn't make up for bad margins. The margins again, to go over it again, invasive cancer, no ink on tumor, DCIS, 2 millimeter margin. So if the margins are clear, the patient will heal up and go for radiation. Radiation, as I mentioned before, decreases the risk of local recurrence by 50%. So radiation therapy decreases local recurrence. It's used for both invasive cancer and DCIS after a lumpectomy. For a mastectomy, indications for radiation are if somebody has positive lymph nodes, positive margins on their mastectomy, meaning too close to the muscle, too close to the skin, or a cancer that's more than 5 centimeters in size. Even though they've had a lumpectomy, the risk of it recurring is higher, so radiation can be recommended. Whole breast radiation is usually every day, Monday through Friday, for about 3 to 6 weeks. There are other options for radiation: accelerated partial breast radiation, which is external, mammocyte, or IORT. Again, different therapy radiation options: whole breast, hypofractionation, APBI, or IORT. What are some contraindications to radiation? Well, as I mentioned before, any prior chest wall radiation, pregnancy, and connective tissue or colon vascular disease that can involve the skin. So again, going over with the patient, any history of scleroderma, Sjogren's syndrome, lupus, dermatomyositis, or polymyositis. These patients, radiation can cause those conditions to worsen or flare up, so radiation might not be the best treatment option with a lumpectomy for them. Patients with homozygous for an ATM mutation, and so anytime you're considering a lumpectomy and there's a question, always get a radiation consultation prior to performing a lumpectomy. So the other option besides breast conservation is a mastectomy. So a mastectomy is complete removal of the whole breast. There are 3 different kinds of mastectomies that we can go over: radical mastectomy, modified radical mastectomy, or what's called a simple or total or complete mastectomy. So radical mastectomy really isn't performed anymore unless there's truly a locally advanced disease where we're trying to get control of it. And so it's a mastectomy, removal of the pec muscle, and level 1, 2, and 3 lymph node dissection. Usually what we perform nowadays is a mastectomy with axillary lymph node dissection. We're not removing the muscle, and it's a level 1 and level 2 dissection. If you're doing a mastectomy with axillary dissection, together that's called a modified radical mastectomy. Now, if you're not removing all of the lymph nodes, if you're just performing a sentinel node biopsy, it's not called a modified radical. It's called a simple mastectomy with a sentinel lymph node biopsy. And again, interchangeable are the words simple, total, complete. But those are just saying we're simply removing the breast and evaluating the lymph nodes separately. The anatomy of the mastectomy. So the anatomical borders to remove the breast is that superiorly you're going to take your dissection to the clavicle, medially to the lateral portion of the sternum, laterally to the latissimus dorsi, and inferiorly to the inframammary crease. Now, for a mastectomy, when a patient, they can either be closed primarily and have no reconstruction. But if a woman is interested in reconstruction, the general surgeon is going to perform one of 2 things. They're going to preserve the skin envelope to allow for reconstruction to happen, and then they have the option of preserving the nipple as well. So a skin-sparing mastectomy is a simple mastectomy that saves the breast skin for immediate reconstruction. A nipple-sparing mastectomy, again, is a simple mastectomy where you're going to biopsy under the nipples. It's called a core nipple biopsy to remove those milk ducts, test those, make sure that from an oncological standpoint, it's able to be it's safe to perform, but it saves the breast envelope and the nipple for immediate reconstruction. Studies with at least 20-year follow-up have shown that the nipple is really just a margin, looks good, but if there's no cancer going up to that nipple, that from an oncologic standpoint, it's safe to keep. The immediate reconstruction or delayed reconstruction options are use of tissue expanders or implants, or using the patient's own tissue. This is either performing a tram flap or a DIEP flap. There are other options for flaps that involve latissimus or other body parts, but this is the traditional one that patients have an option to either use an implant or their own tissue. Next, let's talk about systemic therapy for breast cancer. So systemic therapy or chemotherapy is given to decrease the risk of recurrence. So breast cancer, the goal of surgery for breast cancer is to make a patient cancer-free. The goal of radiation is help for local control to keep them from recurring in that area. Systemic therapy is given to help prevent that cancer from spreading anywhere else in the body over that patient's lifetime. And the recommendations for systemic therapy are based on tumor biology, meaning what type of cancer it is, and again, the tumor stage. So systemic therapy is not based on the type of surgery performed. So, as I mentioned about the receptors at the beginning of this talk, this is where this comes in. Tumor biology. How is this important? How is this cancer growing and dividing? And how fast growing or how risky is it? So, you have estrogen positive, HER2 negative breast cancer. You have estrogen positive, HER2 positive breast cancer. Well, we have triple negative breast cancer or ER negative. HER2 positive breast cancer. And so PR plays a role, but we really don't make treatment recommendations by itself normally on progesterone. It's nice to know, but we don't make definitive treatments at this point based on that receptor. So a few rules to remember for receptors. So if a female's ER positive, meaning that that cancer is growing in response to their hormones, ultimately at the end of cancer treatment, they're going to get endocrine therapy. So if they're premenopausal, they're going to get tamoxifen, and if they're postmenopausal, they're going to be put on an aromatase inhibitor. And these are because they work on different mechanisms of estrogen blocking based on whether or not the ovaries are functioning. If the patient's ER negative, easy to think of. Well, why is that cancer growing and dividing? It doesn't even have an estrogen receptor. So that's a more aggressive cancer, usually faster growing. Those patients respond well to chemotherapy. If that patient's HER2 positive, that means it's essentially got a mind of its own. It's growing its own receptor. And so HER2 positive breast cancer, the good thing is that there are medications that are coming out that target that receptor. And the one that's been out is trastuzumab. There's a newer kid on the block, pertuzumab. But trastuzumab is recommended for that, and that's given for up to a year after treatment. So let's go over chemotherapy. So chemotherapy can either be adjuvant, meaning after surgery, or neoadjuvant before surgery. Chemotherapy decreases the risk of recurrence anywhere in the body. Now, combinations can vary, and I don't want to get you bogged down on that, but really combinations for breast cancer are anthracycline and taxane based. So traditionally what we give is dose-dense AC, which is doxorubicin and cyclophosphamide, followed by Taxol. So that's called ACT. The other combinations that I have listed here is whether or not somebody's HER2 positive. So if somebody's HER2 positive, they're going to get Herceptin and most likely Perjeta. Now, the good thing is that we have drugs that target the HER2 receptor, but they work most beneficially if they're given with the traditional AC chemotherapy, or TCHP is another combination. So these are some combinations that you may or may not see. But the important thing is to know that chemotherapy is indicated for ER negative or HER2 positive breast cancer. So if you know somebody has a tumor biology of ER negative or HER2 positive, most likely they're going to get, the recommendation is for chemotherapy. And so then the next question is, you say, we give it before surgery or should we give it after surgery? So indications to give chemotherapy before surgery or neoadjuvantly is based on three things. So again, if they're triple negative or HER2 positive, then you have to look and say, what stage is their cancer? So any cancer that's more than 2 centimeters, so greater than T2, T2 or larger, or have lymph node involvement. Then you say, okay, they're going to get chemotherapy. Can giving chemotherapy first downstage that patient to make their surgery easier or give them better options? So if a patient has a large cancer where they would prefer a lumpectomy, then giving chemotherapy first would give them possibly that option. Maybe you have a large cancer that's close to the skin or close to the nipple, and downsizing that cancer would give them better options for maybe make them a candidate for a skin sparing or nipple sparing mastectomy. If the cancer is too close to the muscle and you're worried about a positive margin there, that would be helpful. And the other option is to what's called downstage the axilla. So if they're N1, you give them chemotherapy. They're N0, like we talked about before, you're going to be able to give them from an axillary lymph node dissection down to a sentinel lymph node biopsy. So again, first of all, look at the tumor biology. What type of cancer is it? Is that patient going to most likely get recommended chemotherapy? And if that's the case, look at the stage of the cancer and see if giving chemotherapy first would give them better options for surgery. Then those are the patients that you should consider for neoadjuvant chemo. Studies have shown that tumor biology and giving chemotherapy first has a high chance of what's called PCR, so pathologic complete response. And so as you see, a pathologic complete response in the breast and the axilla for a triple negative breast cancer is about 38%. For HER2 positive breast cancer, it's about 45%. So these are good patients. Now, if you can see, if you look at patients that are ER positive in that last column, it's only about 11%. So you never want to overtreat somebody. And I'll get to this in a second on ER positive patients. They're not fast growing cancers, so they're not going to respond really well to giving chemotherapy that targets fast growing cells. But it does work really well for the other patients. So you could tell the patient there's about a 40 to 50% chance that I might be able to not do as much aggressive surgery if you get chemotherapy first. So again, just going over this, triple negative chemotherapy, HER2 positive, whether or not they're ER positive or ER negative, you're going to give trastuzumab. It goes well with chemotherapy. Now, what about this? So what about a patient who's ER positive, PR positive, and their HER2 is negative? How do we determine whether or not chemotherapy would be any benefit to them? And so this is where oncotype comes in. So we know that they're going to get adjuvant chemotherapy. So what is oncotype? So there are other there's side effects to chemo and there are other tests to look at. I'm going to focus on oncotype, but I want to focus on, the side effects of chemotherapy. So chemotherapy does do good things, as I mentioned, but it also has side effects. So the main side effect of Taxol is neuropathy. The main side effect of doxorubicin is cardiomyopathy. And the main adverse effect of trastuzumab is cardiotoxicity. So these are kind of some known things that the medical oncologist will screen for in patients, and these are fair game actually on testing. So you don't want to give patient those side effects if they actually aren't going to benefit that much from chemotherapy. And so one of the recommendations by the NCCN guidelines is to check for an oncotype on ER positive breast cancer. So what is an oncotype? It gives a recurrence score. It tests 21 genes on that patient's cancer. So the cancer is removed, and the patient has a discussion with the physician and say, okay, you're ER positive, what's the risk that this is going to recur? The oncotype tests that patient's cancer and actually gives them a recurrence score. And it's unique to that patient's biology. So there's a low risk, intermediate risk, and high risk. So a low risk is usually about 11 and lower. Intermediate is between 11 and 25. And high risk is usually 25 and above. And so if it's a high risk, you say, you know what, this is a high risk that this cancer is going to come back. Chemotherapy is recommended. If it's a low risk, you say, oh my gosh, this is such a low risk. Chemotherapy is overtreatment. Intermediate risk looks at different factors. So usually intermediate risk, if they're over the age of 50 and their recurrence score is less than 25, no chemotherapy is recommended. If they're kind of in that 20 to 25 range and they're less than 50, it's a discussion with the medical oncologist. But that's how we determined whether or not chemotherapy would benefit ER positive breast cancer. So ultimately for ER positive breast cancer, the recommendation is to take endocrine therapy. So usually it's to take it for 5 to 10 years. Again, if you're premenopausal, tamoxifen. If you're postmenopausal, an aromatase inhibitor. If somebody is premenopausal and they're at a high risk, meaning that they're not triple negative, but they're a high risk, so their recurrent score is high, they're young, um, the option would be to make them postmenopausal, so surgically remove their ovaries or, give them, uh, um, you know, uh, something to put them postmenopausal, and then you're going to be able to give them anastrozole. So again, that's kind of higher level stuff, but aromatase inhibitor for a high risk um, cancer, and it does have some less side effects than tamoxifen. So again, if somebody's high risk or they receive chemo and they're premenopausal, you can suppress their ovaries or remove them and give them an aromatase inhibitor. So how do we determine how long to give somebody endocrine therapy? So before, everybody used to give it for 5 years. We know that endocrine therapy reduces the risk of recurrence as well as contralateral breast cancer. So length of therapy, 5 or 10 years, really is patient preference and tolerability. If they have a stage 1 low risk cancer, taking endocrine therapy for 5 years is good enough. If they're a stage 2 or 3, or they're high risk on their oncotype, and they're tolerating okay, 10 years is probably better. So let's go over inflammatory breast cancer. It's again presenting as erythema of the skin, the peau d'orange, and clinically it's redness of the breast that's our about third or more. It can be a clinical diagnosis, but if you do a skin punch biopsy, the pathology keywords are dermal lymphatic invasion. Whenever you get the diagnosis of inflammatory breast cancer, you definitely want to do a staging workup. And it's a T4 lesion, but it's not a stage 4 lesion. It can be stage 4, but inflammatory breast cancer is T4, not stage 4. It's actually a T4 lesion makes it stage 3. So the treatment for inflammatory breast cancer is, if you think about it, you say, okay, remember, the goal of surgery is when the patient wakes up, they're cancer free. So if it's involving their skin, you can't really do a mastectomy because you're going to leave some skin behind and you don't really know where this starts or stops. So you can't do surgery first. So if you think about it, you say, okay, inflammatory breast cancer, you're going to do chemo. It's going to go through every blood cell, get the cancer out of the skin. So chemotherapy, so treatment timing for inflammatory breast cancer, there is no option. You're going to give chemotherapy first. It doesn't matter what the tumor biology is, it's in the skin. Chemotherapy first. Now surgery is traditional. You don't get the option for sentinel node biopsy. It's a modified radical mastectomy. So this is inflammatory breast cancer is the most aggressive cancer. 5-year survival rate is 20%. So you've got a chance to move on with this. This is timing. This is important. You want to move this patient from one step to the next. You're going to start with chemotherapy. Surgery is a modified radical mastectomy. Again, to review, it's complete removal of the breast, complete removal of the axillary lymph nodes, level 1 and level 2. Reconstruction is not recommended. Lumpectomy is not recommended. You want to get this patient cancer-free and moved on to radiation to help prevent it from recurring locally. If the patient's ER positive, you're going to definitely put them on an endocrine therapy. But again, the timing's different. So it's surgery, not that way. It's chemotherapy followed by modified radical mastectomy followed by radiation in these patients. Let's go over some pregnancy and breast cancer. So I touched on it a little bit. So To be safe, so a safe answer for pregnancy and breast cancer is that sentinel lymph node biopsy, you're using nuclear medicine and you're using blue dye. And we really don't know the long-term effects. There are some studies out there that say, maybe it's safe, it's just safe to say it's really not that safe. We don't really know. The safe answer is that it's contraindication indicated. It may be used, but it's nice to just be safe. And so if you have a pregnant breast cancer patient that you're going to go to surgery, the safe answer is to perform an axillary lymph node dissection. Chemotherapy actually is safe in the second and third trimester. So you can use doxorubicin and you can use cyclophosphamide in the second and third trimester. You want to stay away from taxanes or trastuzumab in these patients. Again, you can't give radiation during pregnancy. You can't give endocrine therapy during pregnancy. And if you have an optimal choice, the optimal time to operate is during the second trimester. So first trimester, you have organogenesis. Last trimester, increased risk of spontaneous delivery. So second trimester, 12, 13 weeks to 23 weeks. The guidelines, it's great to look at the NCCN guidelines for treatment during breast cancer. And again, if you think, if the patient's going to need chemo, you don't want to give them chemo too close to delivery, and you don't want to have some timing where you do surgery and you're not able to give radiation. So this is a good guideline to go through that. But again, surgeries can be performed in an emergency at any time, but ultimately, if you had to pick, it would be in the second trimester. A little bit about male breast cancer. It usually presents at a later stage because males aren't expecting to get breast cancer. So it's usually a delay in diagnosis. Again, as I talked about before, it's usually ductal cancer because men don't have lobules. Any man that gets diagnosed with breast cancer, you're going to definitely do genetic testing. High chance they carry the BRCA2 gene. And overall treatment recommendations are exactly the same as females. So you don't have to treat them. They can have a lumpectomy with radiation if it's small and caught early, or they could have a mastectomy, sentinel node biopsy versus axillary dissection. So exactly the same. I touched on lymphedema before with axillary lymph node dissection. Again, it's chronic swelling of the upper extremity. Can happen with sentinel node biopsy about 2 to 5%, axillary lymph node dissection 10 to 20%, increased risk with radiation. If somebody does get lymphedema, you could do lymphatic massage, you could do lymphedema, compression garments, or physical therapy. One of the bad side effects of chronic lymphedema is lymphangiosarcoma. And so the boards love to ask this. So this is also called Stewart-Treves syndrome. And it's lymphangiosarcoma, and it usually happens with chronic lymphedema after axillary lymph node dissection. It's like this brawny edema of the upper extremity, where the patient will have multiple purple velvety nodules on the arm or breast, and it can happen about 3 to 5 years after the development of lymphedema. It is a poor prognosis, and in some cases it requires amputation of the arm. This is different than angiosarcoma, which is sarcoma of the breast that usually, again, happens with a purplish, almost like a bruising of the breast, velvety raised plaques. Traditionally, it says it's about 10 years after radiation for breast cancer is where you get secondary. You can have primary angiosarcoma, but it's not as common. It's a side effect of getting one of the complications from radiation for a lumpectomy. It's very rare, less than 1%. If you suspect this, then you would do a skin punch biopsy to prove, because usually there's nothing in the breast tissue itself. It occurs on the skin. If you do diagnose somebody with angiosarcoma, you want to get staging scans. The treatment is a wide local excision. So grossly, you're going to kind of mark out 5 centimeters around this to get a local excision. You don't have to perform a sentinel node biopsy because, again, it's a sarcoma. Sarcoma is hepatogenous spread. Um, but because you're doing such wide margins to get around this, you're most likely going to need some type of flap coverage. So um, skin graft is not the way to go. If you can, you want to bring up healthy tissue, so some type of latissimus flap, any type of flap that will give coverage and bring up skin to close. High risk of recurrence, so afterwards you can consider radiation, and occasionally systemic therapy can be recommended. So that goes over cancer in a nutshell. There's a lot of different ways, but this is kind of the breakdown, our talk of cancer.